for short-term external fixator? Certain cases.
When there is a problem of wound.
Wound, about the nature of the wound or the level of bone resection or the vascularity sometimes.
See, this can be tackled by day one by covering the bone wound with the flaps. If you have got a plastic surgeon, he can do a flap surgery and you put a Ilizarov. So it is basically avoiding one more surgery. If you put an external fixator, you have to convert into Ilizarov again. So there are two surgeries which can be avoided.
But sometimes it is very difficult.
Yeah, if you can't manage, then you can do that. Yeah.
You are doing acute docking in most of the cases.
Yeah.
Whenever you feel that it will cause the compromise, vascular compromise to the.
Yeah. Yeah. Very good question. And this is, I wanted to talk about that you should have intraoperative Doppler and you should check the pulse and then only you should leave the operating room. It is very important for surgeon that he should be sure that the pulses are not compromised. If the pulses are compromised, there is another way to tackle this problem by docking inside the ward. What I mean that you leave the gap like that and allow to dock outside, inside the in the ward by 2 mm, 3 mm every day, and then dock it completely. But with experience over a period of 20 years of Ilizarov practice in my life, I learned that if you dock, there is a no blood supply, vascularity is compromised, go back. Do 2-3 times, the vessel gets adjusted, give time to the adjustment of the vessel and you will find that the vessel is present there. So it is your patience on table decides whether it is possible to dock or not. Why docking is important? In India there is a peculiar situation where patients do not want second surgery. And if you can dock and graft and just leave lengthening, then there is only one surgery. If you do transport, there are many complications of bone transport associated with it. Second time you have to go and bone graft it. And all these problems can be avoided by acute docking. Even the union time is decreased if you have a contact bone ends and the union start day one. So it is depend on your expertise that how much you can dock.
Thank you very much. Yeah, Dr. Kulkarni here, you want to ask question? Talk in the mic.
When you are doing acute docking, it is very important that you should see before surgery color of the skin of the foot, pulsation, dorsalis, pedicin, posterior tibial, and pulse oximeter. These three things you must preoperatively note. And then during operation, you must see the color, you must see the pulsation so that you see that the whole sterile area, the foot is all completely sterile area, comes in the sterile area. And then you can do pulse oximeter, ask the anesthetist to do the pulse oximeter during surgery when you are acutely docking. If all three parameters are not in favor of yours, as Dr. Swash said, you do docking post-operatively. If you are docked and your pulsation is lost, color is changed, you immediately undo the whole thing.
I will recommend do not do acute docking if you do not have Doppler inside the operation theatre. You should have a Doppler which is available in 6,000 in India, which is a gynec Doppler converted into orthopedic probe, and you should have that. And you should have a foot, as sir said, completely free so that you can check the pulsation. And even in post-op round also you should check for the pulsation. If it is absent, you should distract and prevent the vascular compromise. Please.
What is the maximum shortening you achieved in the acute docking phase in your cases?
Yeah, I prefer acute docking. I can say I am more in favor of acute docking. I had taken a wrist to the elbow, ankle to the knee, so I had done tremendous docking. And I found it is possible to dock if you have a patience and you are particular about checking the pulse. If your pulse is there, you can dock. There is no problem. But if you do not have pulse, in certain cases, then you dock inside the ward gradually 2 mm, 3 mm per day.
And regarding the bone grafting at the docking site, were you able to bone graft in every case of yours, or in gross infection, you wait for the infection to settle down and bone graft it?
Yeah, that's what I was discussing with Professor Gubin. This is a misconcept. Infection will be under control because of corticotomy. If it is best tool in your hand and you are avoiding doing that, that is the way your infection will not be under control. It is reverse. First do corticotomy, infection will be under control. You are thinking, get my infection under control, then I will do corticotomy.
Not about the corticotomy, but the bone grafting at the docking site.
Bone grafting is not a problem when you have corticotomy. If there is no corticotomy, the bone graft will have a problem because infection is not under control. Any more questions?
Yeah, thank you very much, Dr. Shah. May I invite Dr. Bilin Chowdhury to talk about limb lengthening.
Thank you, sir.
So you want me to speak on limb lengthening or on coronal plane deformity correction, the lecture that I missed in the morning? Mr. Chairman, sir, and friends, I apologize for being late this morning. And the reason was, I must admit, the reason was I was at Bharatpur Bird Sanctuary. And for those of you who haven't visited, there are so many conferences in Agra. That's one of the best things that you can do. I recommend it strongly to Professor Gubin and his colleagues. Don't miss a chance. It's a world-class bird sanctuary. In an hour or two, you may be able to observe at least 20 or more species of very beautiful birds. It's one of the great advantages of having a congress in Agra. Thank you very much for your opportunity to speak on coronal plane deformity correction. This is a cheat sheet to understand translations. The effect of angulation and translation on the mechanical axis is one of the basic things that we need to understand when we do deformity correction surgery. Now you know that these are some of the important angles. A full length X-ray is a must if you are contemplating deformity correction. At least a full segment X-ray. A small X-ray is not going to give you a clear picture. So on a full length X-ray, the two most important angles are at the upper tibia and at the lower femur. Once we have a full length X-ray, you can do that by taking a long cassette. You know, long cassettes are available 14x51, and you stack 3 films with 3 different screens on it, and you can take a standard X-ray, or in the digital system also you have long length films available. With these, when you go ahead and do deformity correction, now we are talking about the effect of angulation and translation on the mechanical axis and how the limb will appear straight and give a good cosmetic result to the patient, but also in the long term give a good functional result without arthrosis. There are certain rules of the osteotomy. The rule 1 states that when you perform the osteotomy exactly where the deformity lies and your hinges are placed in the correct place, that's on the cora, you will get a good correction of the bone without any translation. Okay? For example, in a patient with a varus deformity like this, 55-year-old, here is his mechanical axis, and you can see he's developed medial compartment arthritis. The femur and the tibia intersect at a cora which is over here. So if you perform a rule 1 correction, it's simple. You draw the axis of the proximal and the distal fragment. Where they intersect is the cora. You bisect this angle with a transverse line, and that becomes the axis of correction of angulation. Meaning, anywhere on this line, if you place your hinges, you will get an accurate correction. If you place it at the convex cortex, you will get just an opening wedge in this manner. The limb segment will be straight, there will be no translations. So in this case, we have placed the Ilizarov hinges accurately at the convex cortex. We have done a medial opening wedge osteotomy fixed with the Ilizarov, and you can see that his axis is accurately reinstated to 62 degrees at the Fujisawa point, and this is the triangular shaped bone that has formed. Now, if you need to perform lengthening as well, sometimes patients come to you with a need, they have a shortening as well as a deformity. So you draw the axis, you get the cora, this is your axis of correction. Now you can place your hinge away from the convex cortex and it will give you the length as well as correct your deformity. Such as this 40-year-old who had a growth arrest in childhood, and he has 3 centimeters of shortening and this varus deformity. The intersection gives you a cora here, and we can place the hinges just away from the convex cortex, do a corticotomy, and you get a nice trapezoidal shaped regenerate formation to give you a limb which is completely straight and the axes are restored without translations. Now, not every case is as simple as this. Not all patients come to you with deformities in the diaphysis. Most come to us with deformities in the metaphysis. And we know at the metaphysis, the apex of the deformity is very close to the joint. So how can you fix the small fragment and also perform the osteotomy at the correct location? You can't. So you have to perform the osteotomy not at the apex, but a little away where it is easy for you to perform it and where you can get good fixation above it. But the hinge here is important, is placed accurately on the cora. And when you do that, you get a very good correction of the overall segment. And it's useful, like I said, in juxta-articular deformities and what we call as angulation translation osteotomies. Just to illustrate this point, this is your axis, this is your cora. Now you can't perform the osteotomy here, you perform it at a different level, but the hinge is placed accurately. When you do that, the segment aligns itself wonderfully. There is a minor translation at the osteotomy site which resolves itself by resorption and remodeling over a period of time. But the overall mechanical axis where the body weight passes through the limb passes exactly in the center of the segment or the center of the limb. Now let's take a look at very common examples. This is an orthopedic surgeon. He has medial compartment arthritis. He's 56 years of age. This is his mechanical axis line or the Mikulicz line. You can see it's not passing through the knee joint at all. It's minus 10 or 15%. And we have found that the cora is here. Now how do you give a very reliable result? You do not increase or decrease the limb length, allow the person to walk, allow him to function and go back to work. The best is to do it with the focal dome method using the Ilizarov assembly. The focal dome gives you a very good bony contact because it's an arcuate or a dome-shaped osteotomy done just below the tuberosity. And by using the Ilizarov fixator, you can give sustained compression and get reliable union. Now look over here, this is an arc-shaped osteotomy below the tuberosity, and we have minimally translated the distal fragment laterally. If you observe, it's also translated posteriorly, which is actually done by externally rotating. You have to understand the concept of additive deformities and subtractive deformities. If you want to perform valgus, then a lateral translation will help you more. By doing a little bit of lateral translation, the burden of angulation is reduced. Similarly, external rotation will help you to achieve more lateralization of the mechanical axis. So you can see the patient is walking very early from the second or third day. No blood transfusions are needed, small incisions. He is back to work in 3 weeks' time, conducting an OPD and operating by 4 weeks, and he is full weight bearing by 6 weeks or so. The most important thing is it's a very reliable technique, and they do get sound union because you can always compress without problems. And here is his axis through the Fujisawa point, very well corrected. And he's 7.5 years post-op and he's still having no pain. Now when you have an upper tibial varus, so now what I will do, I will shift the focus of what I'm saying to a more practical mode, okay? The theory we've spoken, now I want to give you a little bit of practical tips. All you need to ensure that your distal fragment shifts a little bit laterally and you can get a very good correction of varus. When you have a lower femoral varus like this girl has shortening, varus in the femur, you can see the LDFA is more than 100 degrees. There is a varus in the tibia with shortening and internal rotation. So in such an instance, it can be useful in urban children who don't tolerate the Ilizarov fixator to perform a lengthening or a deformity correction over a nail. This is a fixator assisted nailing. The key to understand here is the distal fragment at the edge translates medially. When that happens, the mechanical axis can pass accurately through the center of the knee. If you don't do that, then you can have secondary translations of the mechanical axis at the knee joint, and this is a far better thing to achieve. So the crux to remember, whether you're using a plate or K-wires in a child or an intramedullary nail or the Ilizarov fixator or crossed K-wires and a plaster, you need to translate the distal fragment slightly medially in order to line up the axis through the center. In the upper femoral varus, subtrochanteric varus, when you do an osteotomy, the best thing to do is to translate the distal fragment laterally, because the cora is at the center of the femoral head, and this is how it angulates and translates. And this is then further compressed. It gives an immediate stability, and you can see it unites soundly. So therefore, in the upper femoral varus, always translate the distal fragment laterally, unless there is a good reason to translate it otherwise. As in this young lady, she has a dysplastic hip which has become painful, shortening, as you can see in this scanogram, and a lot of lurch. So when you do not want this hip to become arthritic soon, what we want to do is to translate the distal fragment medially. Now the reasons are different. This is the same principle as McMurray's osteotomy or the Powell's osteotomy, in which when you displace it medially, the loads on the hip are reduced by 30%. And that improves the longevity of this hip joint, reduces the loads, improves its longevity. So when you have done that and you need to perform a lengthening at the lower level, so this is a double level correction. If you were to leave this fragment in the same manner, the mechanical axis would now pass significantly laterally in the knee. This used to be done as an operation 70, 80 years ago, 60 years ago, in the 40s, 50s. This is a Milch bachelor osteotomy, and they had arthritis of the knee 20 years down the line. So when you do this, all you need to do at the distal level is translate the distal fragment laterally, as I have shown on this. This is a final X-ray. It has consolidated. The distal fragment has been translated laterally, so that now the mechanical axis passes exactly in the center of the knee. And here is her function with no problems and no lurch. And you can expect the knee to last a really long time, because we don't want to create secondary deformities. Now when you look at a lower tibial varus deformity like this, it is a little subtle, not a very large deformity, but see the joint orientation line. And he has shortening, and he's about to get married. So the parents want him to have a perfect limb. Otherwise, the amount of dowry that they will get from the girl's side would be reduced. You know this, it's a common story, yeah? The girls come because they don't want a single defect remaining, and the boys come because they don't want to get less money. So you need to give him a really good result. You need to lengthen him and correct the deformity. Now, this is the osteotomy performed. If you leave it like this, then he will have a shift of the mechanical axis. As you can see, the axis of the proximal fragment is much too medial. So what you need to do is translate the distal fragment medially, so that the axis of the proximal and the distal line up, and the center of the knee and the center of the ankle are in one straight line. And he has achieved all of his length. Whatever bump is present over here will remodel in a couple of months, and he will not notice it anymore, but he will have longevity. So in the lower tibial varus, you shift the distal fragment medially. When you do that, everything is going to work out. A common condition, the gunstock deformity or cubitus varus, lower varus of the humerus. Very common condition that you can see in your OPD. And this is the kind of picture. You perform a French closing wedge osteotomy in this manner. What will happen? There will be a translation of the distal fragment laterally. And it's not going to create a problem for them because they are not walking on their hands, but it looks ugly. There's a big bump that comes on the lateral side, and it really looks ugly. So what you need to do is, in these instances, all you need to do is shift the distal fragment medially, so that the upper and the lower fragments are collinear in their center, and it doesn't jut out laterally as an ugly, unsightly bump. And they come to you for surgery for cosmetic appearance itself. So therefore it's important that you do not create a secondary translation deformity. And here he is with a very well corrected limb, tiny scars because of the Ilizarov, a very small incision for the osteotomy. You can learn this by and by. You can do it with a really small 5mm incision, and you can really give the patient a good cosmetic appearance and excellent function. So translate the distal fragment medially in lower humeral varus. Now let's come to a few interesting valgus deformities. This is a young girl. She's syndromic, but she has valgus and some shortening in the tibia, in the upper tibia. So what we did with the Ilizarov, we did the lengthening, and also we shifted the distal fragment a little medially. When you have a valgus, when you shift the distal fragment in the tibia medially, automatically the mechanical axis now lines up instead of being way too lateral to being in the center of the knee. Now someone like this is an engineering student. She has multiple exostosis with significant valgus. Now she has mild valgus in the femoral nex, which we didn't want to correct. She didn't want to correct over there. And she has valgus with shortening on one of the sides. And when this happens, we can perform correction at both the levels, do a lengthening, do the osteotomy. As you can see on this side, the distal fragment is shifted medially, all right? And that lines up the axis. And on the opposite side, where we performed the lengthening at the upper level, at the lower level we found that the amount of valgus was too dramatic, so we decided to shift the distal fragment medially as well to shift the mechanical axis. The moment you get a full-length X-ray, the possibility of getting a full-length X-ray, your world expands. You suddenly start understanding deformities in their true context and importance. So I strongly recommend, even if you don't have a CR system, I used a long cassette for 20 years. I got my CR system only 4 years ago, and you can get one for about 30,000 rupees, and it's one of the best investments you can make, even if you're going to do deformity correction occasionally. It will help you for your HTO, it will help you for your TKR if that's what you're interested in. And here is our axis accurately lined up in the center of the knees, and limb lengths are equal, and the treatment duration is very short at only 3.5 to 4 months. So in the upper tibial valgus, we always shift the distal fragment medially. Now, lower tibial valgus also. This is a young athlete who suffered a very unfortunate injury, valgus deformity here. As you can see, there's a fibular non-union, some proximal migration. And what we need to do to correct this valgus angulation is we need to get the distal fragment shifted a little laterally. Just imagine that the cora is over here and that you are angulating around this cora. When that happens, automatically the distal fragment will shift laterally. And when you do that, the axis lines up. You always need to fix these with a foot frame, especially if they are thick set and heavy, like this young lad from Delhi. And you remember that the distal fragment goes laterally in lower tibial valgus. Finally, I will end with perhaps the commonest deformity that you see in practice. That's a genuvalgum, okay? Now, here is this lady from Sweden. She has genuvalgum with only 7 degrees in the femur and the tibia. You can see where the mechanical axis passes. And she has some laxity issues. And the surgeons did not want to operate on her because a 1 degree error in correction can mean a 15% error, which is a little too much. So if you have confidence in doing things accurately, you can do this really well without worries. And the key thing to remember is in the lower femoral valgus, you need to shift the distal fragment a little laterally. Here we have used an LRS fixator for more patient comfort and convenience. You have to remember that the LRS has its virtual hinge at this point. So you have to calculate in which direction the distal fragment is going to move. And even if your osteotomy is much above the site of the deformity, you can achieve an accurate correction. The thing to remember is the closer your osteotomy is to the cora, the lesser is the translation. The further away it is from the cora, the more translation you need to perform to line up the mechanical axis. And we used a Taylor spatial frame distally. When you're correcting an acute valgus in the femur, it's also better to release the lateral popliteal nerve. Now, the same thing is done on the other side. You can see a very subtle translation on the lateral side. It's a small deformity anyway. A little bit of medial translation in the tibia, and see the mechanical axis lines up beautifully. She's able to walk during the entire treatment, and she has limbs exactly the way she wanted them to look, with the axis exactly the way a surgeon would want them to look. When you have genuvalgum with shortening like this, a lot of shortening and significant genuvalgum, when you perform the lengthening, you can do it with the hinges placed over here, or you can translate at the very end of treatment, and you can see the distal fragment is shifted laterally. And here the limb lengths are equal and the axis is a little over corrected because he's still growing, and we want him to have the compensatory effect of the overcorrection by the time he finishes growth. And this is his axis, very slightly overcorrected, and lengths are equal. I think a final example is when you have an adolescent, plump young lady who doesn't tolerate the fixator well. By and by, when the Ilizarov came to India in 1989, when I was one of the first privileged, fortunate, or I would say unfortunate to start, because there was no information available. There were no books except in the Russian language. I made 3 trips to Kurgan Institute, which is the Mecca, which is the birthplace, and still continues to be the source of inspiration and the font of all good things that come from Ilizarov and regenerative technology. So we did everything with Ilizarov. Now we find that India has changed. India is a different country. Our economy is opened up. Much of our population has become prosperous. They are aspirational. They want newer technology. They want lesser time in the external fixation. You know this, a lot of people. So you can correct the genu valgum like this. If a fixator is kept, it will stay on for too long, for 3 centimeters of lengthening. So we do a very good planning. And using fixator assisted nailing with special instruments, we create a track which is accurately at 81 degrees to the joint orientation line, ream over it, lock down or narrow down the canal with polar screws, pass the polar screws like this, okay, on either side of the nail so that the track is not widened, the nail goes up, is locked distally, and a lengthening is performed with the nail kept free above. And LRS fixator pins are posterior to the track of the nail. The length is achieved and the fixator comes off. The lengths are equal, the axis passes through the center. Fixator comes off in 6 weeks or less. This is a big surgery, and there's a need for blood transfusions, better C-arms, more technology, more equipment, but it's definitely worth it when you can take the wonderful technology of Ilizarov and use the other orthopedic technology available to us of intramedullary nailing or plating to achieve the same results for accurate deformity correction. So remember, finally, in a genu valgum, the distal fragment at the osteotomy level goes a little laterally to help you to achieve a perfect mechanical axis. Thank you very much for your attention.
Thank you very much. Any questions, please? Only 2 questions because we are getting late.
Yes.
कुलकर्णी किसका?
Yes.
इनका है ना अभी, फिर कुलकर्णी का देते हैं.
Yes, it's in a little bit of anti-curvation because it helps them. I don't know if I have kept it in this presentation because this talk is about coronal plane. I'll show it to you personally.
Okay, thank you very much. Next speaker is Dr. Dmitry Brezhnov. He is going to talk on bone defects and non-unions.
Currently, most of the authors consider 2 methods of bone transport to be the most effective and alternative ones. Non-free bone plastics by Ilizarov and grafting by complex of tissue with present vascularization, including free outer graft into the defect. Common in the technologies is maintaining vascular connections with soft tissues of the segment, adequate blood sample, resistant to infection and capable of complete organotypic remodeling. Filling in of post-resection radial defect formed after resection of osteoblastoclastoma by free fibula outer graft with venous arterial shunting. Advantages and disadvantages of free vascularized bone outer graft. The first experimental model of filling in post-resection tibial defect by lengthening of the proximal fragment. True bone defect is any loss of bone tissue and total amount of interfragmental diastasis and anatomical shortening of the segment. Defect classification, defect pseudarthros, defect diastasis. In Ilizarov transosseous osteosynthesis adaptation of the docking site, closed and open coaptation of the bone fragments, and maintaining compression between fragments depend on a complex of factors. Congruent ends of bone fragments, closed adaptation. Non-congruent ends of bone fragments, open adaptation. There are different shapes of end of bone fragments. The diagram of creating longitudinal axial compression. Clinical example. Technologies for close consolidation of ends of bone fragments creating side-to-side compression with a long connecting plate. Clinical example. The use of technologies depending on the mobility of fragment. The types of osteogenesis and the types of osteogenesis: hyperplastic, normal, atrophic. You can see the etiology of pseudarthrosis and classification by involvement segment. And in terms of infection, the main aim of treatment and rehabilitation is restoration of anatomical and functional integrity of the limb. The system of reconstructive and restorative treatment of the patient with long bone defects by Ilizarov is based on the following principles to rehabilitation approach: fragments lengthening, healing at the docking site, tibia fibula synostosis, and gradual tension of interfragmental tissue with a regenerate formation. All technologies of transosseous osteosynthesis have fundamental theoretical grounds. Monolocal distraction compression osteosynthesis. The techniques of filling the defect by lengthening of fragments with formation of the distraction regenerate is presented by bifocal osteosynthesis. In modeling conditions of bone transport for the amount of 20% of the original left of tibia, the bone hearing of the distraction regenerate in the docking site was observed by the 90th day of fixation. Multi-level lengthening of the proximal tibial fragment. Polylocal distraction compression osteosynthesis, multi-level lengthening of the proximal fragment. In the experiment in post-resection tibial defect of the same amount by multi-level lengthening of the fragment or opposite fragment lengthening, the duration of osteosynthesis was described by 1.5, 1.7 times. The processes of distraction osteogenesis in polyfocal bone transport were characterized by high level of endosteel and peristeel bone formation. Multi-level lengthening of the distal tibial fragment. Polylocal distraction compression osteosynthesis, multi-level lengthening in the distal fragment. Filling in the tibial defect by lengthening of the both tibia fragment. Polylocal transosseous osteosynthesis, lengthening of fragments towards each other. Tibia fibula synostosis is presented by the method of monopolyfocal bypass synostosis and was characterized by high level of the plasticity and reparative formation of the bone tissue. All experimentally tested technologies of filling in the bone defects and pseudarthrosis are currently widely introduced into clinical practice. Distributions of pseudarthrosis and defect by localization is presented on the slide. The theme on the monolocal transosseous osteosynthesis. Monolocal compression distraction osteosynthesis for pseudarthrosis with angulation. Placement of hands for correction of stiff angular deformity is pseudarthrosis. Patients with diagnosis post-traumatic stiff hyperplastic defect pseudarthrosis of the tibial bone with varus and anti-curvation deformity. Duration of the disease is 3 years old. Transosseous osteosynthesis of tibial bone using Ilizarov5. Osteotomy of fibula and metal removal were performed. Distraction was produced over the traction junctions place of the posterior medial tibia. Full restoration of the anatomical segment integrity was obtained. Patient with aim fails joint. Open adaptation of fragments, compression of the docking site. Treatment result. Bilocal transosseous osteosynthesis. This is him. Patient with diaphyseal ulnar defect. The defect was filled in due to proximal fragments lengthening. There was an open fragments adaptation at the docking site. Patient with defect of tibia bones after gunshot wound, arteriogramma. Defect was filled in due to distal fragment lengthening with overlap of bone fragment ends. Foot quinus was liquidated. There was an open tibia fragments adaptation. The treatment result. One year's follow-up. Polylocal osteosynthesis. Patient with the following diagnosis: 15 centimeters post-traumatic diastasis defect of the right tibial bone. The defect was filled consecutively at 2 levels by lengthening of proximal and opposite distal fragments of tibial bone. 1 year's follow-up. Patient with post-traumatic tibia defect. The defect was filled in due to tibial fragments lengthening to each other, 2 destruction regenerators, the open fragments adaptation. The treatment result. The patient with post-traumatic tibia defect, the was result of proximal fragment lengthening, ischemic regenerate. The defect was filled in due to tibia fragments lengthening toward each other. Ischemic regenerate was compressed. 3 destruction regenerators. The open fragments adaptation. The treatment result. Patient with post-traumatic ulnar defect. Failed joint of radial bone, the scheme of osteosynthesis. The ulnar defect was filled due to consistent multi-level lengthening. The open ends fragments adaptation. The treatment result. Patient with post-traumatic tibial defect, the tibia defect was filled due to consistent multi-level lengthening. The fragments are coherent. The close ends fragments adaptation. The treatment result. Technologies of tibia fibula synostosis. A patient 3 years old, diagnosis with sacrificially of hematogenesic osteomyelitis, subtotal defect of tibial diaphysis, reconstruction of tibia-bound transporting fibula, short-term follow-up after 6 months. We use non-consecutive technologies, decisions for filling in bone defect and correction of pseudoarthrosis using transosseous osteosynthesis. Post-traumatic patellar fails joint, the open adaptation, transosseous osteosynthesis. The treatment is out. The schema of transosseous osteosynthesis at clavicular failing joint, patient with clavicular failing joint. The open adaptation of the fragments ends, transosseous osteosynthesis is made by the scheme. The treatment is out. The other patients with clavicular failing joint, the open adaptation of the fragment ends, transosseous osteosynthesis, the treatment is out. Patients with clavicular defect, free bone plastics by fibula, transosseous osteosynthesis is made in the scheme, fixation 4 months. The treatment is out. Patients with sarcoma Ewinga. Treatment result. Osteogenetic sarcoma of the tibia, post-resection defect falls filled by 1 level lengthening of the distal fragment. Adamantinoma of the right tibia, the scheme of the osteosynthesis. Segmental defect of the tibial diaphysis was filled by lengthening of fragments towards each other. Osteoblastoclastoma, the schema of the osteosynthesis, post-resection defect was filled in by 3-level lengthening of the proximal tibial fragment. The treatment result. Osteoblastoclastoma of proximal metaphysis of the right tibia. The schema of osteosynthesis, free bone plastics, transosseous osteosynthesis. The treatment result. Patient with humeral bone cyst, pathological fracture, transosseous osteosynthesis of the humeral bone, the cyst compression, the wires are covered with hydroxyapatite. The treatment result. Patient 56 years old, diagnosis with post-traumatic stiff failed joint of femur. Deformity was corrected during 30 days. Intramedullary nail osteosynthesis. Patient with round fused femur fracture, shortening is 7 centimeters. The femur osteotomy, lengthening is 2 millimeters a day. Intermediary nail osteosynthesis. Patient 24 years old, diagnosis post-traumatic pseudoarthrosis of femur, shortening is 4 centimeters. Intermediary locking nail. Rare osteosynthesis of the femoral nail, the close remaining of pseudoarthrosis, the compression of pseudoarthrosis with the Ilizarov frame, the lengthening of the femur. Distraction 41 days, fixation 60 days. Short-term follow-up, the Ilizarov apparatus is removal. Distal locking rod. Ilizarov method is currently effective in treatment of patients with a long bone defect. Conclusion. Thank you. Thank you for your attention.
Thank you very much. There are 1 or 2 questions, quick questions. Anybody wants to ask?
You did 3-level corticotomies. What about the soft tissue complications? 3-level corticotomy for bone transport in tibia.
didn't have any problems with skin.
Проблема, возможные проблемы только в васкуляризации фрагментов.
The main problem is with the blood supply of fragments.
Когда вы выполняете остеотомию, 3 остеотомии, вы должны понимать, что отломки должны быть адекватно кровоснабжаемы.
So when you are making 3-level osteotomy, you must be sure that all fragments have good blood supply.
Rate of distraction of each fragment, each level. Distraction level.
Yeah.
How much you distract?
Сколько на каждом уровне?
Все зависит от уровня удлинения.
So it depends on the level of hole enlargement.
Для нас достаточно типичная ситуация, когда пациент поступает с сформированным ишемическим регенератом, допустим, на голени.
So for us it's quite usual to see their bed regenerates, hypovascular regenerates.
В этой ситуации мы выполняем остеотомию не только для замещения дефекта. Вот в этой ситуации ишемический регенерат.
You see it's ischemic regenerate, bed ischemic regenerate.
Уже отключили.
Can you show us presentation again? Please switch on projector. Yeah. It's okay. So it's ischemic regenerate.
Это достаточно типичная
It's
ситуация.
typical.
В этой ситуации мы выполняем остеотомию выше ишемического регенерата.
We usually make another additional osteotomy upper the ischemic regenerate
И имеем достаточно небольшой фрагмент.
and have very little fragment after this.
Но это метафиз.
But it's metaphysis,
Здесь проблем не бывает.
and we have no problem in metaphysis.
Для замещения дефекта еще используем 3-й уровень остеотомии.
So for closing the gap, we're using 3rd osteotomy.
Задача вот этого уровня удлинения
So the aim of this locus of elongation
создать компрессию ишемического регенерата
is to make the compression of ischemic regenerate
и заместить дефект.
and to get away the gap. So to get the bone into the gap.
Мы получаем решение 3 задач.
So we solve 3 problems in one solution, in one frame,
В рамках одной технологии.
in one technology.
3 регенерата.
So 3 regenerates. First one ischemic. Я повторю им просто по почкам. So first one ischemic, and the idea is to compress it, to press ischemic regenerate, bed regenerate. So we make additional osteotomy, and another osteotomy, one more. Why it is so many? Third is to make elongation.
You have used this intramedullary nail with fixator in so
Yeah.
many patients.
Сколько
How frequently you have the infections?
Сколько пациентов были инфекции?
Not wire infection, intramedullary infections.
Были ли инфекции?
Пациентов у нас немного на сегодняшний день.
So not so much patients till now.
Около сотни.
About 100 with nailing.
Проблем с комбинированным использованием на сегодняшний день не было.
But we until now, fortunately, we haven't any problems with the nailing and Ilizarov technique. Because this combination.
К сожалению, у нас есть проблемы с чисто интермедулярным остеосинтезом.
But we have some problems with only intramedular osteosynthesis.
Но оценивая результаты, почему это произошло, мы знаем причины.
But we know the cause of these problems.
Просто-напросто где-то мы не соблюли технологию.
Maybe sometimes we were making some mistakes in the using of intramedular nailing, because we are experts in Ilizarov techniques, but we are not experts in nailing yet. Maybe we made some mistakes.
При комбинированном использовании, вероятно всего, имеется повышенное внимание к этой технологии.
So now we have just new approaches to this, and we take a great attention to this task.
Мы более тщательно отбираем больных
So now we have a very good selection of patients for this technique,
и взвешиваем все риски.
and try to understand all risks and then to make a right decision. So now we have a special program for combinations.
Поэтому пока нет.
So now it's not, for us 100 patients is not a lot.
Okay, thank you very much. May I invite Dr. G.S. Kulkarni to talk on infected non-union.
Infected non-union is common in our country and is really a big problem. Patients comes to you sometimes, डॉक्टर साहब आपने 2 दफ़ा 3 दफ़ा ऑपरेशन किया और भी कमती नहीं है, क्या करने का भी है, poor man. And like that you have a big problem of solving this infected non-union. The Ilizarov method and yeah. Infected non-union, yeah. That's right. Yeah, that's only a. So this problem can be solved by very thorough debrima and stabilization from the day 1 till the last day of union. So there are 2 things which are very important. One is the clearance of the infection. You must control the infection by thorough debrima and antibiotic use of either local antibiotic use by a antibiotic rod. मिलता नहीं पेन ड्राइव से नहीं चालत नहीं है पेन ड्राइव होत नहीं है नहीं सकाळी जमलं नाही नहीं नहीं होता
आप नया डाउनलोड
So we have classified the infected non-union into 3 types. There are various classifications, but I think this is a very good classification. You classify into mild, moderate and severe variety. Type 1 is a mild type in which on 24 hours you press upon and you get a bead of pus. The fragments are in alignment, there is no deformity or no gap. In the second type, the gap is less than 2 to 3 centimeters. There is no shortening, no deformity, but there is a severe infection, the fractures are in alignment. In the severe variety, there is severe infection with deformity, shortening and gap or combination of the above. The treatment is by Ilizarov principles. You may use any external fixator or internal fixator, but use the Ilizarov principles. Principles of treatment of infected non-union is first, to convert an infected non-union into an aseptic non-union by thorough debrima and systemic and local antibiotics. The systemic antibiotic according to the culture and local antibiotic is beads and a antibiotic rod. And as I have told you, stabilization is extremely important. Stabilize the fracture from day 1 to the last day of till the fracture completely united. And then we have added to this application of the vacuum assisted closure if there is a large wound with infection. The debrima must be at the non-union site. Ream the intramedullary canal because it contains lot of granulation, infected granulation tissue with small sequestrae. They must all be cleared by reaming and jet lavage. And resect the bony ends till you get the punctate bleeding, the so-called paprika sign. Now this is the how we make the. Can you run this? It was okay. It was. So we take 40 grams of cement. Yeah, we take 40 grams of cement and take 4 grams of antibiotic. The 4 grams you can make 2 grams of tobramycin or vancomycin or any other antibiotic. The antibiotic must be thermostable and it must be available in powder form. Then you make the rod, take 6 mm or 7 mm K nails. K nail because it is a clover leaf and the cement gets locked inside. So that when you take out the cement, the cement will not remain inside. And then you, over a smooth surface, you roll around and make it completely uniform. And then this step is very important. You pass the antibiotic rod through the nail measure so that you will get the uniformity of the entire thing. Otherwise, if there is a small bump there, then you will get fracture while you are hitting up. You may get the further fracture of the tibia. Then use the beads. Use the cement, remaining cement as beads, and use over a wire, so that you will get beads as well as the cement in about 40 grams of cement, and then twist the both ends so that you can take it out easily, and when you are taking out, the beads will not remain inside. Infected only here, above, just that one. Okay, go down. Okay. The antibiotic used are vancomycin, gentamicin, tobramycin. It gives a high concentration of antibiotic locally, 200 times the concentration than the serum, so that all the bacteria are killed immediately. Elution is very important. It is biphasic. One is the rapid phase, occurs within 1 to 2 days. Majority of the antibiotic is eluded, it comes out of the beads and rod, and then the slow phase starts from the 2nd week to almost 3 weeks, and at 14 weeks you get a very, very small amount of this. So the window period is only for first 3 weeks. After 3 weeks there is no antibiotic. So there is a calcium sulfate beads are now available. The advantage is the calcium gets completely resolved, so that within 4 to 5 weeks there is no need to take out the cement antibiotics where you have used bone cement. Now this is the calcium sulfate used in this non-union. Note this was the sequestrum that was taken out, and there was a non-union here. This is overlapping, and this non-union was filled up with calcium sulfate beads, and there was no need to take out. So within 3 to 4 weeks the fracture united. Within 4 months the fracture united. As I have told you, stability is very important, and you can achieve it by antibiotic rod with an external fixator, and in the second stage you remove the antibiotic rod and insert the intramedullary interlocking nail. Now this is an example. You can see here there is a non-union, and this is not. Now, importance of stability. This is a very important statement. If the fixation is very stable, the fracture can unite even in the presence of infection. I'll show you an example. This pathologist came to us after 10 months of this fixation. There was severe infection, pus was pouring out. This was removed, and we did a thorough debrima and put antibiotic beads. And at 2 weeks, we thought that the infection is completely controlled, and we inserted the Zimmer plate with locking plate with fixation like this. And then we thought this is okay, but on the 6th day we found there was lot of collection inside, and this was again debrided vacuum assisted closure was applied to it, and then there was a small sinus for a long time, but ultimately the fracture united at 8 months. Now, in the treatment of type 1 in mild infection is, again we use an antibiotic, so there is an infected non-union, but notice there was a small infection, not much. It was debrided thoroughly, and antibiotic rod was inserted, and Ilizarov applied was applied, Ilizarov apparatus. This ring is empty ring. It does not have any connection with the bone. So at 4 weeks, with this treatment only, the fracture united in 3 months.